Good morning, everybody. My name is Mark Cohen. I'm a professor in the Gerontology Institute at UMass Boston and the co-director of the Leading Age LTSS Center at UMass Boston. I also serve as a research director at Community Catalyst, a large healthcare advocacy organization. Before joining academia, I founded, along with others, and ran a company that worked with the private long-term care insurance industry. And today what I want to talk to you about is the long-term care financing challenge and why a catastrophic public insurance and front-end private long-term care insurance program would make sense for addressing challenges that we have in this country. So our current approach to financing long-term services and supports for people over age 65 is there are basically four main payers. There are elders and their families who actually bear the brunt of paying for services. Roughly half or so of expected costs are paid by families from savings and so on. And there are enormous in-kind contributions of time and effort by family caregivers. There's Medicaid, the social safety net program, which pays a little over a third of costs. Private long-term care insurance actually has a fairly minor role in current financing of long-term services and supports, and there are other public sources. So you may look at this and say, wow, there are a lot of different ways to pay for services, but there are some significant challenges with our current financing approaches. First, reliance on families alone is becoming really difficult. Smaller family size, increasing employment mobility of children, and the fact that over the coming years, for every person over age 80, there's only going to be 3 people of peak caregiving age compared to 7 today. The Medicaid program, our social safety net, is inadequate. Obtaining eligibility through a process called spend down is a threat to many people's financial security. There are long waiting lists and access limits for home and community-based care. And states are really struggling with budgetary pressure. 35 to 45% of budgets are now represented by Medicaid. Finally, and we saw this during the pandemic, the reimbursement rates that Medicaid pays do not support high quality workforce and service infrastructure to serve and service a growing number of disabled elders. Now, private insurance has really not met expectations, and there are a lot of reasons for that. Just a few things to note. First of all, sales today are lower than they were in 1990. The insurance pays for less than 10% of the nation's long-term care bill, and a significant number of carriers have left the market. There's only about a dozen left. Most importantly, the affordability of the product is out of the reach for many middle-income Americans. And so today, the fundamental long-term care financing challenge is really the absence of an effective insurance mechanism. Now, why do I say that? I say that because an insurance solution really makes the most sense for addressing this problem because of the distribution of the risk and its unpredictability. What you have here in this chart, it shows the probability of having a high need for long-term services and supports. And I'll just make 2 points here. One is you can see that for people turning age 65, roughly half are not going to have any high need. But you do have a chunk of people here between 14%, and then if you look at the 12% slice, they're going to incur more than $100,000 worth of costs. And in fact, 14%, $250,000. So there's this very unequal distribution. And that makes it a perfect candidate for risk pooling. Now, when we talk about insurance, we have to ask ourselves, well, what type of insurance makes the most sense? And here, I've been fairly agnostic between private and public insurance. I'll make one major point. Due to the magnitude of this challenge, a comprehensive insurance solution that relies on both the public and the private sector makes the most sense. This problem is just too big for any one sector to handle on its own. And what I'm proposing here is that the private sector pay first dollar coverage when somebody first becomes disabled, and that the public sector covers back end or catastrophic. Think about that 14% pie slice, covers part of that risk. And the whole idea here is to move our current system away from a welfare basis of financing toward an insurance basis. Now, why am I saying that the public sector should cover the catastrophic piece? Well, there are a number of reasons. First of all, private insurance carriers are unwilling to provide protection for the uncapped back-end risk. There are few policies that cover this risk. Maybe only one or two carriers sell it. And that's because it's very difficult in a voluntary insurance market to price this risk. And the cost makes it really unaffordable for people. And so what you have right now today is the middle class is incredibly exposed for financial catastrophe during old age. Why? Because the poor and near poor, they can rely on the Medicaid program with its challenges, and the wealthy can self-insure. So middle income elders are the most vulnerable and are the target of the approach I'm talking about. Now, why would the federal government be best suited to provide insurance for back-end risk? Primarily because of market failure. Oftentimes, the government steps in when insurance is not widely available because the industry cannot collectively absorb or affordably price the insurance risk. And there are precedents for the government doing this. Think about national flood insurance, terrorism insurance, even unemployment trust fund, and so on. So when there's market failure, the government tends to step in with a solution. And even if the private insurance market were more viable, not everyone could afford to purchase or would qualify for private insurance coverage. So promoting a very robust solution that relies on both the private and the public sector insurance is one way to improve quality, address service infrastructure problems, and reduce levels of unmet need in the population. So the key organizing principle of catastrophic insurance is that we want to limit exposure to amounts that middle-income people can reasonably be expected to manage themselves with insurance or savings. And here, I'm talking about individuals may be responsible for somewhere between 1 or 5 years of care before the public insurance takes effect. Private insurance then would have the opportunity to market products as first dollar protection to encourage modest income people to purchase policies and build a comprehensive insurance solution. So part of this also involves encouraging innovation and trying to entice carriers back into the market. Now, how would a family take care of the immediate need before the public insurance kicks in? Well, as I've said, there's the opportunity to buy less costly, more limited private insurance plans. You can think about employers paying or supporting family caregivers to provide care during that period. There's savings. There are some new benefits from Medicare Advantage plans with long-term care supplemental benefits. And if tax penalty-free retirement fund withdrawal is approved, then there's an opportunity to use funds for that. What happens when you implement a catastrophic public insurance program? What this chart shows is what happens if we do nothing, and then what happens if we have what we call an income-related waiting period or just a fixed period. And here, there are three things that happen. A, there's a very large reduction in Medicaid expenses. B, there's a reduction in out-of-pocket expenditures. And C, more money would flow into the system to support our infrastructure. So in closing, I want to reiterate, there are significant benefits with this approach. It allows people to plan with certainty for what they will be accountable for and have the government act as a backstop. It will help to encourage a vibrant and private insurance market that middle income people will be able to afford. and it will stream significant new benefits into the system and reduce Medicaid expenditures.